So it's really my great pleasure to introduce our CME speaker today, Dr. Brad Tinkle, who's coming to us from the Peyton Children's Hospital in Indianapolis, where he is a clinical geneticist. Dr. Tinkle received his PhD actually in DC at GW, went to medical school in Indiana and did a pediatric and clinical genetics residency at Cincinnati Children's Hospital Medical Center, where he stayed on his faculty. He subsequently became the medical director of clinical genetics at the Advocate Health System in Chicago, and he was then recruited again to the Peyton Manning Children's Hospital in Indianapolis. He has a long interest in care for individuals with heritable connective tissue diseases such as Ehlers-Danlos. He's extremely well known and well published in this particular field, and so I've asked him to come today to talk a little bit about hypermobility syndrome, which I've just been struck about how often I see this in rheumatology, but also really how often it affects multiple different specialties in medicine, anywhere from GI to primary care to neurosurgery. And I think it's a very, very neglected disease in general in medicine. And so I'm really happy that Dr. Tinkle is here to educate us. So thank you very much, Dr. Tinkle.
So I do want to talk about joint hypermobility and its comorbidities, because it is important to recognize hypermobility has a mechanical issue to it, but there are things that are associated with it that can be quickly sort of addressed and help the patient along the way with overall quality of life. Just a few disclosures. I can make this slide set available to you guys so you have everything here. One of the things I want people to sort of realize is joint hypermobility is a very broad term, because what we're talking about, increased range of motion, has a lot of other verbiage, being double jointed or hyperflexible, joint laxity, loose jointed, whatever. I do have patients that sometimes I'll ask if they're double jointed and they'll say no, but they'll say yes to joint hypermobility. So realize the terminology makes a difference when you're eliciting history. But the joint itself is a complicated structure between bones. So bone dysplasias can cause joint hypermobility, muscle tendon, neuromuscular disorders, ligaments laxity, and other disruption of the soft tissue elements within the joint itself. So we talked about the joint structure itself, but joint hypermobility can obviously be described in many different ways, whether it affects one joint, whether it affects multiple joints, and are they the small joints like the fingers and digits, or is it large, and then is it more generalized, is it affecting all the joints, and et cetera. Is it symptomatic versus asymptomatic? Michael Phelps, you can look at his elbow, and the elbow looks very unusual there. And so he has elbow hypermobility. That's not the only thing he's hypermobile for, but doesn't seem like he's in any pain or discomfort. Whereas the athlete in the other screen has shoulder hypermobility and shoulder dislocation and looks fairly distressed about it. So it can be asymptomatic, it can be symptomatic. The beighton scoring system is probably the most common ways that we evaluate for hypermobility. The pictures on top are common, how it's used as far as looking at the dorsiflexion of the fifth finger relative to the back of the hand, thumb apposition to the forearm, knee and elbow hyperextension greater than 10 degrees, and whether or not you can put your palms flat to the floor upon standing with knees straight. It is the most common system, but it also has a lot of nuances to it, and some of these nuances need to be better worked out. The scoring system does score right and left independently. People may have differences based on injury or surgeries, but we also see some slight differences between left and right, depending on the handedness or the footedness of the individual. This is another depiction, and part of the reason why it's another depiction, because as we started talking about the beighton scoring system and what we would like from it, et cetera, we all realized that we do this differently. And we didn't think about it. It's just like, oh yeah, we'll see if a person can sort of bend. So you see here, the person bending forward, that should be a simple, straightforward description of what to do. The person's in shoes. Does the shoes make a difference? Well, technically it does. There's a certain distance there. Does it make a difference if your elbows hyperextend when you're extended fully in front versus towards the side? My physical therapy colleagues have learned to do knee hyperextension measurements while laying down. And so our patients standing up. So there are a lot of different things that we have to figure out. The attractiveness of the beighton system was the simplistic nature of it. The problem is we actually need to do better to use this as a clinical tool and make sure everybody's on the same page. It does come from the Carter-Wilkinson, and you'll see 1 through 4 is pretty much the same. The fingers, the dorsiflexion was all the fingers versus just the 5th finger, and it used foot dorsiflexion, whereas the spine flexion is in the beighton criteria. So a lot of overlap. We can't really say one is superior than the other. The beighton is more currently used, and so later studies have done a better job looking at the beighton scoring system as far as its reliability, the inter-rater reliability, which is much better. The Hospital Del Mar criteria came out more recently and is more complicated. It's usually measurements of less than 21 millimeters. Some of the degrees and stuff are not typical for how we measure things, and other things are not described. Patellar hypermobility. Well, how do you judge that? So there are different criterias that's out there. The beighton by far the most common. But there are differences because there are reasons why we don't necessarily aren't fully satisfied with the beighton criteria alone. So it is preferred, as I mentioned. However, when using it, there's a point where we say something is hypermobile, and then you also have generalized joint hypermobility. And so that's a scoring threshold. So that itself is a controversy. Is that different based on age? Is it different based on gender, pupil status, ethnicity, and et cetera? The short answer is yes. The long answer is we don't know how much that slides left or right, up and down that scale to sort of accommodate those particular things. And it only sort of measures a few joints. So I get criticized when somebody comes in and says, my shoulder's dislocating all the time, and I'm measuring their elbows and pinky and thumb, and they're like, but you're not measuring my shoulder. And, you know, it's one of those things that it's a little bit more complicated to measure hypermobility of the shoulder. You can look at instability. And so it's just one of those things that, you know, should the system for hypermobility assessment really include more of that pathological assessment versus just an assessment of range of motion. We also don't know why some people who are hypermobile are symptomatic and relatively asymptomatic. And so why is this? This can go back to a lot of different pathophysiology that underlies this. We do know that gender and hormonal status plays a role both in the hypermobility, but also in pain and pain perception. People who are trained, like Michael Phelps, if I showed that picture to a bunch of emergency room physicians and kind of hide the context, they would probably say, oh yeah, that elbow is dislocated. But if I, you know, zoom back and here's, you know, somebody who has no problem with it, it's not an issue. I've shown pictures where their fingers lay flat to the back of the hand, and I'm thinking this looks like a mafia picture, somebody breaking somebody's fingers. And so there are people who are extremely hypermobile, and the manipulation of their joints are relative asymptomatic, but people who are somewhat stiff and even borderline hypermobile complain more of pain. So we don't understand those mechanisms. Pain itself is very difficult from both a biological perspective and a psychosocial perspective as well. Because this is also a heritable disorder, we have a lot of people who may come up as a child or young adult and complain about their hips or their knees, and other people in the family have the same kind of thing, and they pretty much normalize that pain. And so a lot of people don't really realize that it's abnormal to have that level of pain. And so a lot of people become later in adults and 30 and 40 and will tell me, I didn't know that that was normal. That was something I grew up with. That was something accepted in the family. And now I've realized this shouldn't be normal. The one thing that's, I think, been one of our more recent wins is the American Rheumatology has recognized that joint hypermobility can be a problem. It has been part of joint hypermobility syndrome in the past and is still a part of that. However, it's one of those things, I think it's been downplayed mostly because of this association with EDS, Ehlers-Danlos syndrome, and the controversy around that diagnosis and the comorbidities that people put out there for EDS. And because of all that murkiness, then a lot of people, I think, have gone away that, let's be simplistic here. Does joint hypermobility cause an issue? And a lot of times we do see issues around it. And this is a one sheet that comes from the American College of Rheumatology. I love to hand it out to my adolescents and my young adults, kind of to help validate them as well. That it says it recognizes joint hypermobility is something that can be seen, can be associated with pain. It may be part of a connective tissue disorder, but that's less likely. It's more or less symptomatic joint hypermobility. It may have a tendency to run in certain families. One of the other sections just basically said some of the common symptoms. Basically, it goes through the beighton maneuver. So these are the things you might be able to do. You may have pain. You may have chronic pain. You may have activity-related pain. You may have a tendency for injuries, sprains, strains, etc. Itises, soft tissue rheumatism. You may have flat feet. You may have balance coordination issues. You have increased bruising. Matter of fact, the American Society of Hematology has now recognized it's always been in the differential for increased bruising, but in their current diagnostic algorithm, they basically say you're going to draw all the blood and do all the different things. But if all that's negative, what you're going to do is actually you're going to start bending the patient. And if they're hypermobile, the bruising is likely related to the mechanism why they're hypermobile. And so now we have another professional society that's coming forward and saying these are things associated with hypermobility. There, of course, when most people have talked about this, they worried about these other syndromes, Marfan and Loeys-Dietz and Ehlers-Danlos and osteogenesis imperfecta, etc. Most of these outside of hypermobile EDS, which definitely is a spectrum along sort of that symptomatic joint hypermobility syndrome, most of those are relatively rare. There are certain things that should be triggers for you to think about. And that's not the common patient that most of us are seeing walk into our office. And so it's one of those things I think that's great to sort of think about and worry about. Is like when somebody has a headache, let's think about what causes a headache and not worry the person has a brain tumor unless we're hearing something that makes us worried. They have seizures, there's a family history of brain cancer, they have a glioma, something that says I need to be worried at a different level. So some of the other things that can be signs of other worrisome connective tissue disease, the skin features here, atrophic scarring where the scar has healed but then kind of spread apart, the hemosiderin deposition of just constant brewing, tissue fragility. Gary Stretch shows you his comedic routine where he tends to stretch everything. Eye findings, high myopia could be something like Stickler, Loeys-Dietz, Marfan syndrome, especially if there's dislocation. Other weakness of the soft tissue, diverticular hernias, especially multiple hernias or incisional hernias, those should make us think about there's a soft tissue connective tissue problem. Joint hypermobility, you'll see I'll bring in there. It's also been associated with sort of lower blood pressure and orthostasis, sometimes called POTS, but it's just one of those things that we should also be aware of. There are some that may have aortic root dilatation. That is not a common feature among those with a symptomatic joint hypermobility syndrome. If we hear of it or if we hear a family presentation of aneurysms, then those are things that we should think about. This is more the syndromic type of joint hypermobility. in the context of something like Marfan, Loeys Dietz, those things that have to be evaluated for. Developmental dysplasia of the hip or club foot could be early signs of vascular EDS, the Marfanoid body type, pectus, broken bone, skeletal dysplasia. All those should be red flags in the context of joint hypermobility, that there should be somebody who is then further screening for a heritable disorder of connective tissue. So in the population, who are we talking about? In general, we're talking about everybody, but there are certain factors that tell us one population is greater than the other. Hypermobility itself, much more common when you're younger. That doesn't mean the consequences are more common younger. It just means that they're more likely to be hypermobile. As we get older, we're less likely to be hypermobile, but those with hypermobility early may develop more chronic pain conditions and not have hypermobility later. Gender, there's definitely a female to male ratio, often quoted as an 8 to 9 to 1. Ethnicity, definitely Asian, African population are much more commonly to be more hypermobile. You can train to be hypermobile. And so a lot of times we'll see our gymnasts and dancers and etc. However, as kids grow up, if they're the child who can sit there and do the splits with very little effort, very little work, they get attention for that. They get told, oh, you should be a dancer, you should be a cheerleader, and etc. Information from the London Ballet that have been looked at since the 1960s suggests that the ones going into the early ballet schools at 11 years of age, nearly 40% will have intrinsic joint hypermobility, but they do not last to the high levels of competition. So that suggests that the joint hypermobility is a gift that they can use. Unfortunately, if they can't control it, they won't be able to sustain those kinds of activities at that level. And we see it in kicking sports and throwing sports and et cetera, where hypermobility can be an early benefit, but a burden later. And obviously, when we're tracking sort of prevalence, it depends on what criteria we use and what number we use for that. This is just a scatter plot showing how it changes with age. More likely to have a lower beighton score if you're older, and the inverse is true. This just looking a simple graphic, basically amongst different geographic groups, which include ethnic groups, men and women discrepancy, where women typically is significantly different, but in some groups not that much different. So a lot of times in the North American population, the incidence is about 10 to 15%, but we're definitely more of an admixture population. This is one of the studies I do like and I tend to use a lot for various different reasons. This came from sports medicine. They were very interested in why females tend to have more ACL knee injuries. And the speculation has been a hormonal status, but it's also recognized that joint hypermobility has something to do with it. And so under these pre-participation examinations, they did the video analysis and had a lot of fancy equipment, but they also did the beighton scoring, et cetera. What came across to them that they were surprised about, that we kind of knew amongst people with joint hypermobility, but this was incredible data that supported it, was early on, pre-pubertal, males and females, as far as hypermobility, were pretty much the same. However, in puberty, we would see presentation of females, but we would hardly see a presentation of a male. And this really says, as you look at the pubertal status, you see a difference, a significant difference between males and females as far as their generalized hypermobility. And the reason why they looked at it, and not their data also suggests one thing, but at the same time, there's other studies out there that when you look at the generalized laxity, and looked at knee injuries, especially ACL injuries in West Point cadets, you see a 3 times increase for men and 5 times for women. If you look at knee hyperextension injuries, 5 times greater risk. So recognizing that hypermobility isn't necessarily just a problem at the start, it's a problem that can be in certain activities. And so there have definitely been talk amongst military recruits, should we screen for hypermobility? Because if you're at an increased injury risk, does the armed services want to invest? And you could think of sports the same way. Do they want to invest all this money to get you trained to a certain level to find out you start having injuries that cost their medical system and or put you sort of on the bench where you can't participate? And so in the military, a lot of these folks will end up on their medical disability. And so a lot of times there's thought about, should we screen them ahead of time to make sure that it's something that they can sustain? The scoring threshold makes a difference. This was three nice studies. The first two are actually two different studies looking at Indian school children. So one could argue really about the same age population and ethnic population, but looking at a beighton score of 4, which is not a commonly used, but has been used in literature. Almost 60% qualify for generalized joint hypermobility, whereas the second study used 5 and basically was 40%. So obviously the prevalence numbers changes a lot depending on the number. The Turkish study actually reported both scores at 4 and 5, and you can see it cut the number by more than half by moving up the scale. So it's unfortunately our medical literature a lot of times just calls it generalized joint hypermobility, but sometimes they use a different scoring threshold. So a lot of that, when we're doing sort of medical literature review, a lot of times gets very confused when people are using the scoring threshold all over the place. So recognition. Well, geneticists are typically pediatric trained. I'm at a pediatric hospital. I do see pediatrics and adults. And so it's not unusual for the peds that sometimes they're wanting to come in and show me their greatest trick. The adults usually recognize, I used to do tricks, but it kind of hurts now, so I don't do it. But that's one of the first things, if they have anything different, unique, that's one of the first things they want to do. They want to sort of give a visual history, essentially, visual review of systems. Look what I can do with my hand. I can put the legs behind my head. I can do this, I can do that. Some describe it, some do it. And so it's interesting when they sort of start to perform. And I think for some people, they expect a shock. And by now, I think I've seen it just about all. So it's one of those things that is like, okay, we'll talk about that. One of the things, though, I do look at is just mechanics. How do they stand? And I realized, a number of times in our offices, we don't even see the patient standing. Patient comes in, sits down, gets their blood pressure, heart rate from the nurse, sits there, doctor comes in, starts talking, puts them on the exam table, has them sit and has them lie. And then a lot of times, even if we're doing a knee assessment, back or whatever, we're not seeing them stand. But standing makes a big difference, because if you're hypermobile, a lot of times you have compensatory mechanisms going on. People with knee hypermobility, like our young swimmer there, often will tilt their pelvis forward, hyperextend their lower back, and then to compensate to get back to that plumb line, they'll round their shoulders and they'll drop their head forward. So it is one of those things that the mechanics of things, we can work on the knees. I can tell her to straighten her knees, but she has compensated in different places that we have to work on. And so a lot of times with my physical therapists, I give them a lot more free rein. I just say there's a group of joint issues, and I want you to look at everything to make sure things are being treated, because one region in the body can definitely influence the other region. They also tend to have a flexible foot, which we'll talk about very briefly. But with that, sometimes they'll collapse their arch. They'll have a heel valgus. And as they grow, they'll get genu valgum. They'll get femoral anteversion, and then they'll get hyperlordosis again and chronic low back pain. And so the ortho has named that the minimal malalignment syndrome. And that's important to recognize early childhood, because as we treat the mechanics of that, we can influence how the bone grows. The seated posture is also important. Too many of us work in front of us these days, and so we're sitting on a computer or whatever else, and the more things get digitized, the smaller things, the input devices, and so being an iPad, a laptop, or whatever else, and so the adopting the posture makes it harder, and a lot of people who are loose jointed quote kind of hang on their joints. They go to their extreme flexibility. Their muscles get used to sort of allowing the body that way, and then when we ask them to actually have good posture, they complain it's painful because they're assuming a very different body posture, and the muscles have gotten weaker. This is a quick slide on the flexible flat feet. It's most of the time when people have their shoes off, they're not weight bearing. They'll say, "No, I have an arch." But you know, poolside or when they're walking flat-footed, you may hear a flap. You may see just a broader footprint. When they're standing, a lot of times the arch goes away. The plain asymptomatic flexible flat foot, I don't care that much about. It's about the mechanics. And so when I see that, if there is a heel valgus, then we like to correct that, because that will change the dynamics of what happens through the posterior leg all the way up to the lower back. Handwriting kind of going out the window these days, but definitely in kids. But other people who use repetitive hand tasks, some of the doctors still use it. Every time I get to an electronic medical system, I'm still documenting a lot by handwriting. So it's just one of those things that what happens is in a typical grip, because of the looseness of their fingers, the little muscles in the hand overcompensate. That reduces their endurance. And so the longer they do it, the worse the writing gets. And so I get told they're going to be a doctor someday, and it's like, well, hopefully not if they write that bad, because that's still a bad thing to do. Hopefully they can type better. But it's one of those things that they're kind of aware of, that this is an issue, but they don't know how to address it. And sometimes they don't even know to bring it forward. They talk with the teacher about it and whatever else and say, oh, it's just little Johnny. Well, maybe it needs to be attended to in a different way, because in some of them it causes pain. They stop their work. They become oppositional because it's kind of like punishment. You know, you're told to write this and it hurts. You stop doing it. And so we see a lot of school conflicts, but definitely a lot of people who use repetitive tasks with a fine motor, with the endurance, get to be a problem with their occupation as well. So other common scenarios that we sort of see is just an abnormal gait. They're often kind of awkward or clumsy. There is a proprioceptive issue with these individuals that have joint hypermobility. So with the ankles kind of turning in, we get some instability at the ankle. We get some proprioceptive defects. You throw in maybe some weak core, fatigue, those kinds of things, and we get people run into things, falling down, and we get a lot of fall injuries. EDS and joint hypermobility have been associated with fractures, and it's technically not correct. Epidemiologically suggests it's not correct. However, I do have people who fracture a lot, and basically the fractures are very typical of somebody falling. Their foot, ankle, and forearm fractures because they try to catch themselves. And so they'll fall repeatedly and they'll have repeated fractures, but they're not fragility fractures. So those are things that can be sort of looked at and thought about. But again, to me, this is more of a mechanical issue more than anything else. Now, everybody worries about, well, what if it's something else? So obviously EDS comes up a lot. What if it's EDS? The different types of EDS most usually are fairly clinically present so that you're going to see them and know something's different. You may not know the label, but you're going to know this is different. The symptomatic joint hypermobility is somebody who comes in and looks perfectly normal. And so if we say EDS, the prevalence has been about 1 in 5,000. However, that's old data, didn't even look at all the different forms we have, and really neglected the hypermobile type. if we look at the symptomatic hypermobile type, and whether we call that hypermobile EDS or joint hypermobility syndrome or some variation thereof, you're actually talking anywhere from 0.5 to 2% of the population. So it is very common. And it's going to show up in a lot of different places, as Dr. Bunker had said. And so, unfortunately, the EDS folks want to call themselves zebras, just like the old analogy when you hear hoofbeats, think horses, not zebras. And I'm telling everybody, I want you to think horses, because this is so much more common medicine than it is looking for the uncommon things. This is just a quick table of the different EDS types in the last nosology. 13 different ones. Hypermobile type has no genetic defect associated with it, which makes it then difficult to have a more objective measure of the diagnosis. So that adds to the problem of where hypermobile EDS starts or ends and symptomatic joint hypermobility begins. And so a lot of us sort of look at this as a spectrum. That hypermobile EDS may be at one end of the spectrum, but a lot of times we're talking about the same issues and overlapping issues, and where to draw the line between what's hypermobile EDS and not hypermobile EDS is somewhat arbitrary, and on a clinical level does not help the patient at all. It's a detriment to the patient to try to divide them into two population groups. I tend to use joint hypermobility syndrome more often in my adults because it is a little bit more simplistic. It does not have the controversy around EDS. And so it's one of those things, to me, it's cleaner diagnosis. Basically, the context, people who have been hypermobile start complaining of joint pain, don't have any signs or symptoms of an inflammatory arthritis, don't have any other obvious causes for it. They have to have some level of chronic pain. We would prefer them to be currently hypermobile, but as we age, the hypermobility tends to go away. So at least a convincing history that they have been hypermobile. And we see this a lot of soft tissue rheumatism, dislocation, subluxations. They may have a slight bit of connective tissue phenotype, like the marfanoid habitus. The skin might be a little stretchier or whatever else. And so those are the things that have been described back when the Brighton criteria was set out. This is the 1998 version of it. And so a lot of that still looked like a connective tissue disorder. The only thing that it wasn't put in context here is that it might be a familial disorder. This came from rheumatology, whereas genetics, we're going to pay attention to family. And so what happened is this came out. It's a little bit cleaner. It's still a subjective diagnosis. It's still kind of, you exclude all the other reasonable things, but it was one of those things that's kind of a nice label. The only thing I don't like about the label is the fact that it's called benign joint hypermobility syndrome. And the problem is when it's called a chronic pain syndrome, and that's part of the diagnostic criteria, is that's not benign. But in the context of the 1960s, when it was originally described, it was meant to be not life-threatening. It was meant to separate it from Marfan syndrome. And so effectively, we've dropped benign to call it joint hypermobility syndrome or hypermobility syndrome. However, when I put it into my computer system on the code, the same code pulls up benign joint hypermobility syndrome, joint hypermobility syndrome, and et cetera. And so when that gets translated to other providers and they get listed as benign joint hypermobility syndrome, they go, oh, you're just hypermobile. It doesn't cause a problem. And so in some ways, we still need a better terminology of what we're talking about. And the EDS label isn't there yet. This isn't quite there yet. So we're still in a quandary about what to call this symptomatic hypermobility. That's a label. That's not necessarily the treatment part. So this was a quick side-by-side comparison of hypermobility syndrome versus hypermobile EDS. There is significant overlap between the two. One of the common questions I got from my rheumatology colleagues is, how do you tell the difference? Well, the one thing, the diagnostic criteria that was different, or two things really, was the family history and the skin features. But the skin features are fairly subjective. joint hypermobility syndrome did have like loose skin, thin skin, whatever else. So one could argue it was about the same. And so it was difficult to really tell the difference. Most geneticists being pediatric trained, we would see a child, we would call it hypermobile EDS. The child presented sometimes very asymptomatically because they were overly flexible. And the mom would come in and say, you know, hey, I was like that. Nobody listened to me. I want to make sure we take care of our child so they don't have the chronic debilitating pain that I have. Well, what do you have? Well, I have fibromyalgia. I have seronegative rheumatoid arthritis. I have all kinds of different labels used to describe the same thing, but very commonly, joint hypermobility syndrome would come up. And so it started becoming sort of, for the people who treated both pediatric and adults, it was like, well, why do I have joint hypermobility syndrome for every parent that walks in the door, but we call it EDS? And so once we started talking different disciplines, different age providers, all of a sudden we're like, well, we really can't tell the difference between these two. And so we did come out with a statement some years ago that basically said, we can't clinically tell the two, so they're clinically indistinguishable. The problem has been since that statement is that even if we wanted to be a little puritanical and kind of keep descriptions different, people have started using them interchangeably. So the current literature over the last 10 years, if you talk about hypermobile EDS or joint hypermobility syndrome, a lot of times they're used interchangeably. But even before that, when you look at the criteria, when you look at the natural history that's been described in literature, there were a lot of things that were described by both conditions, just in a different timeline. But it was really hard to pick out, even beyond the diagnostic criteria, that the syndromes looked very similar. And so we're confident that we're really been talking about the same population, but what is still the best label, what is still the best diagnostic criteria is still significantly debated. So when we talk about symptomatic hypermobility, some of that is definitely talking about the mechanics and the musculoskeletal pain, but there are other things that can be associated with it, and some of it is just pain, some of it is other things. This is a nice graphic from joint hypermobility syndrome that basically said joint pain is greater than 90%. Now, since joint pain should be one of the things part of that criteria, one could argue that's kind of an ascertainment bias. In order to get a joint hypermobility syndrome diagnosis, you pretty much have to have joint pain. But I think this also sort of broadens things out and shows that it's not just a musculoskeletal issue. Fatigue was the second common complaint. And today, whether I call it EDS, hypermobility spectrum disorder, joint hypermobility syndrome, fatigue is still one of the most pressing complaints that they have. And so this mirrors a lot what we experience today, whether it's almost 20 years ago. Some of the things that were also seen surprise us a little bit, but some of these we definitely know from other chronic pain conditions, fibromyalgia, and et cetera, that non unusual pain can interfere with sleep and mood. It may cause more anxiety, more depression, and you might have other things that sort of come out, sometimes kind of wrapped up as just a chronic pain syndrome. One of the other things that we saw among joint hypermobility syndrome and amongst people that we label with hypermobility is more fainting, more orthostatic symptoms, and et cetera. And so those were things that we saw very commonly. And if you look at it as a dysautonomia, then some of the other things that we were seeing, the tachycardia, the GI dysmotility, and et cetera, some of those could be easily placed into, if I'm revving up the sympathetic system, the parasympathetic system is going to be off kilter too. And so we would see autonomic symptoms that kind of fit in the picture. And one of the difficulties has been that a lot of people would have these seemingly desperate types of symptoms. And amongst the EDS community, they would say, oh, well, if you can't connect them, think connective tissue. And I understand that banner and that logo and whatever else, but as clinical scientists, we want to make sure that if we're seeing a picture, the things should kind of come together if we can piece the pieces together. So a lot of it just has to come to recognize that if you have orthostasis and tachycardia, near syncope, and we call it POTS or neurocardiac syncope or whatever else, that's a dysautonomia. But things that go along with it include like sleep dysfunction, thermoregulatory problems, GI problems, and et cetera, and sort of realize and acknowledge and validate the patient that these things can sort of run together. Pain, like every pain condition that you all deal with, it's complex. It can be local, it can be generalized, widespread. Most of the pain that we see is more of a myalgia pain, but they definitely can have nerve pain, they can have chronic pain. A lot of them will have a chronic pain and then sort of acute exacerbations, and that could be daily exacerbations on top of it. Early on, they may be called more like growing pains or pure activity related pains. Pain can obviously interfere with sleep, and then you get that sleep pain cycle where decreased sleep makes you more sensitive to pain. You get some degree of relief from the pain because of this activity related component. It doesn't really help with the chronic pain as much. With the muscle tension, you often still get a morning stiffness from that, so it takes a little while for those muscles to start to respond. Increase after activities, etc. I had some people who would work a fairly physical job and basically spend the entire weekend in bed trying to recover to go back to their physical job. And so it's one of those things that sometimes it's just that excess physical activity was causing so much pain that a lot of times we were going in the wrong direction. So when that happens, when activity produces pain, then people want to be less active. And so they can have just a fear of being more active and causing pain flares. So kinesiophobia or just generalized anxiety can do that. They'll start using braces and splints inappropriately. They'll use them more often, causing more weakness and deconditioning of the muscles. That causes more joint instability and etc. So these are often a downward spiral once they start to self-treat. Pain, by many measures, is very different. I like simple little clinical questionnaires. I don't like my pain's a 10 or whatever else because, quite frankly, every patient is different of how they do that. Serially, the pain score might be helpful. One thing I learned early in my career, my patients would come in and say, my pain's a 6, and I would set up the management strategy and et cetera, and they'd come back months later and say, my pain's a 6. And I'd be like, darn, I don't know, these things should be helping. And then they turn around and say, well, it is helping. I'm actually a happy 6, and I was a depressed 6. And I'm happy 6 because my pain got less. I started doing more. My pain came up, but because I was able to do more, had a better quality of life, I've been living at 6 for so long. 6 is fine. What I really wanted was that functionality. And so it became that I can't treat the score, I got to treat the person. And so using things like the brief pain inventory, especially the pain interference scores, was kind of helpful because that would say, hey, I cook less, I socialize less, and et cetera. Same thing in like the fibromyalgia questionnaire and other questionnaires that look at sort of quality of life outcomes. So besides more of this activity-related pain, episodic pain, there's definitely chronic pain. So most of them are reporting that they have some level of chronic pain, and about half of those reporting their chronic pain feel like they're moderately to severely disabled from that. Many come in with a dual diagnosis of fibromyalgia. And so there have been a lot of studies that basically have overlapped and said those with fibromyalgia tend to have more joint hypermobility and vice versa. And the graphic kind of shows you that there is some overlap looking at joint hypermobilities in those two population groups down there. And so there was always a greater significance of joint hypermobility being in the fibromyalgia group as compared to controls. One of the books that I use a lot, mostly because it has some excellent joint therapy chapters in it, for the child, adolescent, and adult, written by occupational and physical therapists that I illegally hand copy and hand out, to give to the therapist so that they have something to work from, because a lot of the stuff we do is subtle differences, but we want to make sure it's done right. And so this was a book that sort of recognized that joint hypermobility, it's not joint hypermobility syndrome, it's not EDS, whatever. Joint hypermobility causes mechanical stress that cause pain of long enough duration on a daily basis to call it chronic pain, and then some go on to develop fibromyalgia. So I think it's always been a good book, as far as kind of explaining that association, but I think it's one of those things, we need better messaging beyond that. The fatigue, just like there was 92% that had chronic pain, about 92% also report sort of a disabling fatigue, and that interferes with activities of daily living. I am much more focused on that functionality than I am pain, but then I am fatigue or any kind of qualifier. I really work hard on my patients, and I consider it more holistically, is we want a better life for you, and I'm not going to work towards a pain goal or whatever else. I'm going to work for a functional goal. Dysautonomia is fairly common. There's multiple papers. This was one of the earlier ones, and basically said if you look at blood pressure control, look at orthostasis, dizziness, and etc., 88%. That was, I would say, in our population, I quote around 75%. With a dysautonomia, they can have obviously tachycardia. They can get headaches from it. They get a lot of brain fog. That includes the impaired concentration and confusion, forgetfulness, but they also get a physical fatigue as well as that mental fatigue. Again, one of the things I'm glad, there are plenty of times when patients come and seek me out, and it looks like they're doctor shopping. And so when they go back with Dr. Tinkle says all these things are related, and here's the plan and whatever else, it's not unusual that I get comments back as, they think you're a quack or whatever else. And so, yes, I carry some influence amongst the EDS, but outside EDS, a lot of people don't know who I am. And I'm not saying they should do exactly what I say, but it's nice having certain organizations say joint hypermobility is an issue. And so we had American College of Rheumatology, American Society of Hematology, and Mayo. I don't really think Mayo is better than any other place, but they're definitely known for their dysautonomia. And so this is a very nice handout that I give a lot of my young adults or adolescents, because it says this has some risk factors to it. The first thing is being a teen. The second thing is being a female, and that's the pubertal connection. And so in a typical adolescent with no other risk factors, there is a transient response where they tend to be the swooning adolescent girl. And that's because of this altered regulation. And if you look at hormonal dysfunction later on in menopause, you will see a lot of dysautonomic symptoms then too, again, because of the hormonal influence. So it's one of those things they said, oh, by the way, the people who are at risk for this, teenagers, Caucasians, females, high achievers, and I tell everybody, a lot of times the high achievers are the anxious people. So if you're already riding some level of anxiety, and this causes a lot of adrenaline surges, you're probably going to present with, hey, I'm having more panic attacks, or my heart's really beating through my chest, or whatever else. But the last bullet point there is the people who are flexible, double jointed. So they're at more risk. And they're at risk because the same connective tissue that comprises the tendons and ligaments and et cetera is the same part of the vascular interstitium, and it still has an elasticity component. And if we just easily think of hardening of the arteries increases blood pressure, loosening of the arteries, a more elastic artery actually decreases blood pressure. So it only makes sense. And we do have studies that use ultrasound and et cetera that show arterial elasticity is increased in those with generalized hypermobility. Sleep disturbance is extremely common. I find it one of the more complex things to deal with. But again, it's somewhat acknowledging that's different. This was a nice study that compared controls, fibromyalgia, and EDS. And you can see EDS and fibromyalgia were significantly different in their sleep quality compared to controls, but pretty not significantly different between the two. I like this slide only because I have set in on conversations, presentations on headache disorders, on GI symptoms, on chronic fatigue, on chronic pain, on dysautonomia, and they all have this sort of ball and stick figure, and their particular thing is in the middle. And so it's one of those things that becomes, this is kind of a common pathway for a lot of these more chronic disorders, chronic pain disorders. And so it's one of those things I think we also need to recognize that chronic pain disorders tend to have a clustering of these different things, that this becomes more complex than just sort of tackling the joint hypermobility, but a lot of times we got to pay attention to these other things and sometimes work in a better multidisciplinary way to sort of make sure that there is an overall improvement. But validity of these things also makes a significant difference for our patients. The therapy, I just have one slide. It's obviously more complex, but it's probably a longer conversation. And so the therapy is recognizing those other things and starting to treat it. Postural education, mechanical support, neuromuscular reconditioning, the balance and proprioceptives is very important. And I show the pictures here because what happens is sometimes when they get sort of a list of exercises, and ortho often will sort of say, go do these things, is they'll do them mechanically incorrect. And you see the person up in the upper right in the picture hyperextending her elbows. If she continues to have repetitive load on her arms, she will complain of pain. If we tell her not to fully extend her elbows, she'll work the same muscles, a little less inefficient, but at the same time, she will not produce the same pain. Many of my patients have tried physical therapy and have been hurt by physical therapy and don't want to return. And so we have to convince them that this is the right modality for them. I want to thank you for your time. And just, you know, it is one of those things that we want them to be active, we want them to go, but we do have to give them the right guidance and et cetera. So thank you once again.